Welcome to the Training and Access Project's Community Resource Series. This series is centered on connecting schools and community resources to support collaboration and connection. The Training and Access Project, or TAP, is an initiative within Boston Children's Hospital Neighborhood Partnerships and offers professional development for school communities to support building capacity to address social-emotional learning and behavioral health in schools. Today, we have the opportunity to hear from clinicians from Boston Children's Hospital, both from the Developmental Medicine Center and Outpatient Psychiatry Services. We would like to welcome Virginia Peisch, Heather Potts, Marissa Dennis, and James Lynch. We also want to thank Catherine Barahona-Pass for her work on this presentation. Within this video, they will share key information about ADHD, pathways to diagnosis, and provide some strategies that school communities can use. Following their presentation, you will have access to resources, and we will share contact information. We thank you for watching and hope you enjoy the video.
Hi, I'm Dr. Peisch, and I'm a clinical psychologist at the Developmental Medicine Center at Boston Children's Hospital. My colleagues and I are so excited that you've chosen to join this webinar on ADHD. We have 3 clinical psychologists from Boston Children's Hospital with us today: Dr. James Lynch, Dr. Marissa Dennis, and Dr. Heather Potts. Over the course of the next hour, we will share how we, as clinicians in an outpatient clinic, partner with educators and families in supporting students with ADHD. We've organized our talk into the following 3 sections: what is ADHD and why it matters to schools, ADHD assessments and diagnoses, and treatments and supports for students with ADHD. This information is not specific to ADHD care at Boston Children's Hospital. We'll be reviewing general practice guidelines for pediatric ADHD. We're dedicated to providing culturally informed care, and we've integrated such considerations throughout this talk. At the end of this talk, we'll share some of our favorite resources with you, such that you can continue to educate yourself on this topic and provide support to your students and their families. So let's jump right in.
I'm Dr. Lynch, a postdoctoral fellow at Boston Children's Hospital, and I'll review the basics of ADHD and highlight why and how it matters in schools. Attention Deficit Hyperactivity Disorder, or ADHD for short, is one of the most common neurodevelopmental disorders. Neurodevelopmental disorders are those that are considered to result from differences in how the brain develops and functions over the course of early childhood and throughout the lifespan. An estimated 11% of children and adolescents in the U.S. have received an ADHD diagnosis, which means that in the average elementary, middle, or high school classroom, 1 or 2 students have an ADHD diagnosis. Although ADHD is more frequently diagnosed in boys than in girls, research has shown that symptom presentation and impairment tends to be pretty comparable across the 2 genders. ADHD consists of 2 groups of symptoms: those related to challenges regulating attention, which we call the inattention symptom domain, and challenges regulating behavior and impulse control, which we call the hyperactivity impulsivity symptom domain. The Diagnostic and Statistical Manual, 5th edition, or DSM-5 for short, is written by the American Psychiatric Association to outline the diagnostic criteria of all the different psychiatric disorders. Here, you can see the 18 symptoms of ADHD as defined by the DSM-5. There are 9 inattention symptoms and 9 hyperactive impulsive symptoms. The inattention symptom domain focuses on difficulties with maintaining and regulating attention and concentration, while the hyperactive impulsive symptom domain focuses on difficulties with regulating behavior in a way that is appropriate to the environment. To receive a diagnosis of ADHD, a few things must be true. For children under the age of 18, the child must have at least 6 symptoms of inattention and/or 6 symptoms of hyperactivity impulsivity. Importantly, symptoms must be present in at least 2 different settings, such as at home, in school, at extracurricular activities, or with friends. Symptoms must be present for at least 6 months and have started before the age of 12 years, and cannot be better explained by another diagnosis. We will go into more detail on this a bit later in this webinar. Lastly, symptoms must be associated with what we refer to as functional impairment, which means that not only are they present, but they disrupt daily functioning in meaningful ways, such as by interfering with learning in school, making friendships, or limiting engagement in extracurricular activities. Many students with ADHD struggle at school and in the classroom. We want to give you some examples of what that might look like. A student with ADHD might make careless mistakes on assignments, such as skipping a problem by accident or not answering all parts of a question. They may also forget to hand in assignments or hand them in late, even if they completed them on time. They might have difficulty staying seated at their desk and often be in and out of their seat to move around the classroom. They could be chatting or otherwise disrupting their neighbor in the classroom instead of listening to the teacher or working on their assignment. They may shout out answers to questions without raising their hand or being called on. Many individuals with ADHD also have difficulties with what is called executive functioning. Executive functioning refers to a set of cognitive skills that include inhibition, the brain's brake pedal, working memory, the ability to hold on to information in mind and do something with that information, and cognitive flexibility, the ability to adapt thinking to different contexts. Executive functions help us with more complex skills, such as problem solving, reasoning, planning, and self-control. Together, these skills are essential for regulating behavior and navigating complex and challenging situations, such as completing a big school assignment or playing a play date with a friend. Students with ADHD and executive functioning difficulties often struggle in the classroom, particularly as academic expectations increase. For example, 2 children might be having a hard time completing a word search in class and are getting frustrated because they can't find a specific word. A child without ADHD might let out a quiet ugh and then try finding a different word. This reflects their ability to effectively use behavioral inhibition, keeping their frustration to themselves, and cognitive flexibility, switching to a different target word to manage a challenge. However, a child with ADHD might get stuck on finding that one word, reflecting cognitive inflexibility, and yell out in frustration and throw their pencil, reflecting disinhibition, even though they know that they're not supposed to yell or throw things in class. Many children with ADHD continue to display ADHD symptoms into adulthood and experience impairment in daily functioning that is related to those symptoms. Estimates vary depending on how adult ADHD is assessed, but 40 to 77% of children continue to experience significant difficulties with ADHD as adults. Importantly, the way in which ADHD symptoms present can differ across the lifespan. Over time, challenges related to hyperactivity tend to become less apparent. For example, adults with ADHD are not typically running around or climbing excessively or treating their house like a jungle gym. But adults with ADHD may continue to experience difficulties with feeling restless or impulsive, or maybe have sought out careers or hobbies that allow them to be more physically active. Or they may avoid situations that require large amounts of patience. Difficulties with inattention, however, often persist into adulthood and may even become more apparent. This is, in part, because environmental expectations change. Adults are often expected to pay attention for longer periods of time compared to teenagers, and careless mistakes or procrastination may cause greater negative consequences, such as missing a payment deadline or making costly mistakes at work. Part of the reason why symptoms change over time is that the brain is continuing to develop and mature all the way through early adulthood. The maturation of the brain has been found to be delayed in children with ADHD compared to typically developing children. The darkening colors represent the physical maturation of those brain regions, with the maturation of ADHD brains being delayed approximately 3 years on average. It's really important to take a strengths-based approach with ADHD and to recognize the many assets and skills that affected children have. In fact, children and adolescents with ADHD can have all the same strengths that typically developing children can have, being sweet, funny, caring, driven to succeed, and intelligent. They're often outgoing, energetic, and curious. There are many famous and successful people who have shared their ADHD diagnoses. Michael Phelps, Simone Biles, and Emma Watson, just to share a few. Educators play a critical role in helping students with ADHD take advantage of their many strengths and reach their full potential in the classroom. Unfortunately, by definition, individuals with untreated ADHD experience significant disruption in daily functioning due to their symptoms. Youth and adults with ADHD are vulnerable to increased health and mortality risks, including suicide, substance abuse, and car accidents. They also frequently experience social difficulties, such as poor social awareness and being more likely to be bullied. Lastly, academic and occupational challenges are particularly impactful, such as poor grades, poor work performance, and lower total earnings. In school, challenges with attention and behavior regulation can negatively impact countless areas of daily functioning. Students with ADHD may lose lots of points on assignments for careless mistakes. Their quality of work might suffer from rushing through assignments to get them done as quickly as possible, or putting them off to the last minute. They may often get spoken to or otherwise punished for interrupting, leaving their seat, talking while the teacher is talking. Students with ADHD may also experience rejection from their peers or social isolation due to immature behaviors. These behaviors and the resulting negative feedback from peers and adults may hurt a child's self-esteem. So now that I've reviewed the basics of ADHD, you might be wondering how it is diagnosed in the clinic. I'll now hand it over to Dr. Dennis, who will tell you about ADHD assessments.
So thanks, Dr. Lynch. I'm Dr. Dennis, a postdoctoral fellow at Boston Children's Hospital, and I'll be talking about what students, educators, and families can expect during an ADHD evaluation. So who can diagnose ADHD? An ADHD diagnosis can be made by a pediatrician, primary care provider, psychologist, or other specialized clinician. Many pediatricians are able to make an ADHD diagnosis after gathering information from multiple sources and ruling out a potential medical condition. Why would someone want an evaluation? We generally suggest an evaluation when children have difficulties regulating their attention and behavior. Figuring out why a student is struggling in the classroom can provide guidance on how to support them. Educators play a really important role in this process because they are often the first ones to notice a student struggling at school, and they have a really good sense of how children that age typically behave. So educators can partner with families by sharing their concerns with them and by empowering them through knowledge. Given that different cultural, religious, and racial and ethnic groups may have distinct views of ADHD, it is very important for educators to listen to families and learn about their understanding of ADHD. When talking with families, educators can share their observations and discuss the impact of attention and behavior regulation difficulties on the child's experience in school. If educators need support when talking to families about these concerns, they can consult with their school-based behavioral health providers, such as a school counselor, social worker, or psychologist. Educators can also point families to resources. They can help facilitate a meeting between a family and their school-based behavioral health provider, who can also then talk to them about their child's behavior and help make a referral for an ADHD evaluation. Educators can also encourage families to talk to their pediatricians about ADHD. In addition to having conversations with students and caregivers, a key role of educators in this process is completing rating scales and questionnaires that will be shared with providers, such as a pediatrician or psychologist. The teacher's perspective is essential because ADHD symptoms must be present in multiple settings for a diagnosis to be made. Your observations in the classroom provide valuable insight into the child's functioning beyond the home environment. One commonly used and free rating scale is the Vanderbilt Assessment Scale, which can be used for children between 6 and 18 years old. This slide shows the 18 ADHD-related questions of the Vanderbilt scale. For younger children, teachers may be asked to complete the ADHD Rating Scale 4 preschool version or the Connors Early Childhood Teacher Form. When completing these rating scales, teachers can think about how the child's behavior and attention compares to other students of that age. So, for example, compared to other 6-year-olds, does this child make more careless mistakes or seem distracted by their own thoughts? Teachers can also write comments at the end of the scale about some of the difficulties a child may be experiencing related to school because of their difficulties with inattention and hyperactivity. For example, they may comment on school-based functional impairments such as high rates of missing and incomplete homework assignments, a disorganized desk or backpack, or a tendency to blurt out answers in class. A thorough ADHD evaluation that is completed by a pediatrician or psychologist typically includes a review of the child's medical and school records, which is necessary, for example, to rule out difficulties with vision or hearing, clinical interviews with parents, the collection of teacher and parent rating scales, as I described earlier, behavioral observations of the child, and screening for other potential emotional and behavioral concerns, such as anxiety and depression. This is important because children with ADHD also often meet diagnostic criteria for an additional clinical diagnosis. If a child is found to have a clinical level of ADHD symptoms, evidence of symptoms across at least 2 settings, and functional impairment related to the symptoms, then an ADHD diagnosis may be made by the psychologist or pediatrician. Not every child exhibiting ADHD symptoms will meet diagnostic criteria for ADHD. In fact, there are several other conditions that can mimic aspects of ADHD. Providers are faced with the challenging task of ruling out alternative causes that may present like ADHD. This includes medical conditions like sleep difficulties or exposure to lead, which happens mostly in very young children, as well as other psychiatric issues such as anxiety, depression, or a specific learning disorder. The challenge here is to figure out why a child is inattentive or hyperactive and impulsive if they don't have ADHD. As an example, in the case of anxiety, children may be inattentive because they are distracted by their worries. Similarly, children may be dysregulated because they've experienced a traumatic event or chronic stress. They may be fidgeting with their hands or have difficulty concentrating because they are nervous in relation to their prior stressful experience. As another example, children with specific learning disorders or learning challenges may also appear to be inattentive in the classroom because they are having a hard time grasping concepts or completing assignments. Teachers can help providers make these important distinctions by sharing relevant information with them. For example, is there a time of day when symptoms are more severe? What other things is the teacher noticing about their student? Are symptoms only present during reading activities? That might give us a hint that the child has a specific learning disorder in reading, also known as dyslexia. Is the child mostly fidgety when they are asked to speak in front of the class? Then it might be social or performance anxiety rather than ADHD. To tie all of this together, ADHD may be ruled out based on a variety of reasons, including 1, the child does not meet the required symptom severity threshold. 2, there is not sufficient evidence that symptoms are causing functional impairment. 3, the symptoms are not observed in multiple settings. For example, if a parent notices symptoms at home, but the teacher does not observe them in school. And 4, the symptoms are better explained by another condition. For example, as in the case of a child with an anxiety disorder discussed on the last slide. If a child does not meet diagnostic criteria for ADHD, we recommend continued monitoring of ADHD symptoms and possibly the treatment of the alternative diagnosis. So let's say that your student was found to have a specific learning disorder in reading. Then we would recommend that they receive services through an individualized education program, or IEP, to address learning gaps. Should ADHD symptoms continue to be apparent, then a reevaluation may be warranted. Neuropsychological testing is a comprehensive assessment process used to evaluate strengths and weaknesses in a student's thinking and learning abilities. We do this by using tasks that were developed to measure specific skills like memory, attention, language, and executive functioning. So, when is neuropsychological testing needed? A standard ADHD evaluation conducted by a pediatrician is typically sufficient for a diagnosis. However, for children with complex ADHD, further evaluation by specialists, such as developmental behavioral pediatricians, psychiatrists, or clinical or neuropsychologists may be necessary. The term complex ADHD refers to ADHD that coexists with an additional neurodevelopmental or psychiatric disorder. For example, autism spectrum disorder or learning disabilities. When there are multiple coexisting concerns, determining the presence of an ADHD diagnosis and treatment can be more challenging. In these cases, a comprehensive evaluation should include a specialized provider gathering a comprehensive medical history and completing neuropsychological testing. Although neuropsychological evaluations are comprehensive and provide families and providers with important information, they are time-consuming, difficult to access, and expensive. As such, pediatricians should typically be the first step in the assessment process, with more specialized testing reserved for more complex cases. I'll wrap up my time with you all by discussing important cultural considerations in ADHD assessment. ADHD occurs across all cultures, but cultural perspectives on attention and behavior challenges vary. What might be perceived by a teacher or clinician as hyperactive could be seen by a family as lively or having fun. Likewise, there can be great variability in perceived causes of behavior. For example, a child who is making careless mistakes on homework assignments may be perceived as not trying hard enough instead of having challenges managing inattention symptoms. There may also be stigma surrounding mental health and child development. Some families may be hesitant to seek the opinions of clinicians or see difficulties as something that the child is going to grow out of. Building relationships with families can help establish trust with providers and help them feel more comfortable and supported during the assessment process. Of notable concern, research indicates a significant healthcare disparity. ADHD is underdiagnosed and undertreated among Black, Latine, Asian American, and Native American children in the United States relative to their white peers. The reasons for ADHD diagnostic disparities are complex. Importantly, factors such as language barriers, cultural differences, rater bias in the assessment process, and limitations in access to healthcare may reduce the likelihood of ADHD diagnosis and treatment in certain populations. For example, research related to rater bias in the assessment process suggests that white parents are more likely to report ADHD symptoms in their children compared to parents from racially and ethnically minoritized communities, which may reflect cultural differences in symptom perception, stigma, or trust in healthcare systems. With this information in mind, there is a need for culturally sensitive ADHD assessment. This type of assessment acknowledges and integrates cultural factors into all stages of the assessment process, from selecting appropriate tools, interpreting results, and sharing results with the family. For example, a culturally sensitive assessment can include working with interpreters and cultural brokers and including questionnaires in a family's primary language. By collecting information from families in multiple ways, such as through translated rating scales and within interviews, clinicians can cross-reference different sources of data to assess the presence of ADHD symptoms, as well as gain an understanding of how a family's culture may have influenced their report of symptoms. Clinicians should also reflect on their own cultural biases and perspectives as they review assessment data and work with families. Educators also play a critical role in the culturally sensitive assessment process. Here are 2 key action points to keep in mind. First, educators should also reflect on their own cultural biases and how their perspectives may influence their role in the ADHD assessment process. For example, how they complete rating scales. Next, educators can share resources with families to help reduce barriers to care. We will provide resources in the resource folder on the website associated with this webinar and encourage you all to share them with the families you work with who may need them. Now I will hand it over to Dr. Potts, who will tell you about the treatments and supports schools can provide for students with ADHD.
Thank you, Dr. Dennis. I'm Dr. Potts, and I work as a clinical psychologist in the Department of Psychiatry and Behavioral Sciences at Boston Children's Hospital. This final section will review evidence-based treatments for ADHD with a focus on how educators can support students with ADHD in schools. In all decisions about treatment, we always want to partner with families to come together with a plan. Treatment recommendations for children with ADHD are based on age. For children under the age of 6, it's recommended to begin with behavioral interventions before medications are tried. For children aged 6 and above, clinical practice guidelines recommend the use of FDA-approved medications in combination with behavioral interventions. Medication can be particularly beneficial for the treatment of moderate to severe ADHD symptoms that are interfering with functioning, and there are a lot of FDA-approved options. The most common medication class is stimulants, including mixed amphetamine salts and methylphenidate, commonly known as Adderall and Ritalin. These medications are generally fast-acting and can start working within 30 minutes, although it may take about 1 to 2 hours for them to reach peak effectiveness. Non-stimulant medications, such as guanfacine or atomoxetine, can also be beneficial in a wide variety of cases, such as if the child is having negative side effects to stimulants. Medication formulations can be short-acting, which lasts about 3 to 6 hours, and long-acting, which lasts about 8 to 12 hours. How long a medication lasts depends upon how quickly the body processes it. Students who take short-acting medications may need to take a second dose during the day, often called a booster dose, to provide coverage later in the day, which the student often takes in the school nurse's office. There are several variables that a prescriber considers with choosing medication, and school observations are incredibly informative in this process. Some providers may ask that you complete rating scales regularly to monitor a child's response to medication, or parents may routinely ask for your observations about how their child is doing in response to a change in medication. I know that myself and other providers always appreciate the school's input, so regular communication with parents and with the child's providers, if you have a release of information, is always appreciated. Now, some parents may choose to not medicate their child, or they may be hesitant to do so. School staff can continue to support parents who opt out of medication by fostering open communication and collaboration, including updating the parents on their child's progress and challenges. And always continue to support the child with behavioral interventions, which we're going to talk about next. Additionally, recommending resources such as ADHD-focused workshops or the BCH ADHD guides can be beneficial in providing parents with evidence-based information to help them make the best decision for their child. While medications can certainly be helpful in targeting symptoms, we encourage teachers and caregivers to use positive behavior management strategies both at school and at home. These strategies often include learning how to praise expected behaviors, to use reinforcement systems, to ignore certain behaviors, and to use clear communication. We will focus on supporting students with ADHD in the classroom while also providing you with resources that you can share with parents and caregivers on ways to support their child at home. For example, the BCH ADHD guide, which I mentioned earlier, contains several strategies that you or the parents of your students may find helpful. Schools can support students with ADHD within the Positive Behavioral Interventions and Supports, or the PBIS model, which is an evidence-based, 3-tiered framework for supporting all students' academic achievement, social, emotional, and behavioral well-being. ADHD can manifest in various ways, which means that some degree of individualization is necessary. And as Dr. Lynch described earlier, ADHD symptoms also often change across the lifespan, which means that supports may also need to change across time. We encourage schools to collect data to guide their decision-making and to regularly monitor students' progress. We also recommend collaboration with school staff, parents, and other providers to identify appropriate supports and services for the student with ADHD. Within a PBIS framework, Tier 1 supports are universally and proactively implemented within the school to support all students. Multiple studies find that students with ADHD thrive in environments that utilize positive behavior management strategies at this Tier 1 level, and you may already incorporate several of them into your classroom. And while a comprehensive review is beyond the scope of this webinar, we would like to highlight a few key strategies and encourage you to visit www.pbis.org and our ADHD guides previously mentioned for additional tips. One important way that educators can support children with ADHD is by creating a structured and predictable learning environment. Predictability reduces anxiety and stress and the cognitive demand of figuring out what's coming next. A few simple ways to make settings more structured are with clear rules and expectations that are fairly and consistently applied, visual schedules with previews of anticipated changes, clear and effective instructions. This includes first obtaining the child's attention and then clearly communicating what the students are expected to do next. Now, secondly, students with ADHD are also more likely to receive criticism throughout the day, which can unintentionally reinforce problem behaviors and lower a child's self-esteem. Two ways to counteract this are with labeled praise, or calling attention to the things that you want the student to keep doing, and teacher greetings, or positively greeting each student as they arrive in class is another simple strategy to foster a positive student-teacher relationship, and which has been shown to help with student engagement and compliance. Some students may need more targeted interventions. In most public schools, teachers can refer students experiencing behavioral difficulties to a Tier 2 team, which is a group responsible for designing and refining interventions to meet student needs. One well-established Tier 2 behavioral intervention is the Daily Report Card, the DRC, which can also be known as a Daily Behavior Report Card or a check-in, check-out plan. So here's an example of a DRC. And a DRC can be used to focus on about 3 to 5 target areas for improvement, such as work completion, compliance, raising your hand before speaking. DRCs are completed by the teacher throughout the day, and children are provided that great labeled praise for successes or given constructive feedback if they're having any difficulties. The DRC travels home at the end of the day as a means for teachers to communicate with parents about whether their child met their goals for the day and provide their child with tons of praise and sometimes a little reward for meeting their goals. Children with disabilities, including ADHD, may also be eligible through the special education evaluation process for individualized supports or services to help them access their educational program. In schools that receive federal financial assistance for education, including public schools, children may receive these services under a 504 plan or an individualized education program or an IEP. Children who are parentally placed in a private school or homeschooled may still be eligible to receive education supports and services. And you can learn more about how students in private schools can access supports by contacting the Massachusetts Department of Elementary and Secondary Education, or DESE, and we have included the website in our resources at the end of this presentation. Now, while service delivery can differ across schools and districts, the goal of these plans is to help provide individuals with disabilities equal access to education and to support their educational program. Some common school accommodations for those with ADHD include preferential or strategic seating, which is an accommodation that aims to minimize distractions between a student and their teacher. And for most children with ADHD, that means being seated in the front of the classroom, which allows teachers to observe their students' engagement and behaviors and provide those great prompts for redirection as needed. Movement breaks have been found incredibly beneficial for ADHD, including increased attentional abilities. We encourage educators to schedule break times for physical activity, such as stair climbing, or even consider flexible seating arrangements, such as standing desks. Fidgets are certainly popular, and some find it incredibly helpful in certain settings as a self-regulation tool. However, sometimes fidget spinners can be distracting to the child or those around them. So monitor their usage, and check in with them to see if they're still finding it beneficial. Structured study hall can also be beneficial for students with ADHD who need individualized small group or one-to-one support with learning material, executive functioning skills, guidance on study skills, assistance completing assignments, and monitoring work completion, with the ultimate goal of building independence. Schools can also help students with ADHD develop skills that support their learning and enable them to access the curriculum. Students with ADHD often report executive functioning difficulties, and they benefit from learning tools and strategies for organization, time management, and planning. Two popular examples are teaching students with ADHD how to use resource notebooks and planners. The hope is that students with ADHD will continue to use these tools as they move through the educational system and into the workforce. They are going to graduate one day. And it's a great way to foster independence from an early age. In fact, the amount of support that you, the educator, provide the child with ADHD will shift over time. Initially, you will teach the skill with the help of worksheets or templates. Then you will provide some support before you gradually fade the amount of assistance that you provide. The ultimate goal is to help children with ADHD be independent in their work. And now I'm going to hand it back to Dr. Peisch.
Thank you, Dr. Potts. We've covered a lot of information today, and we hope that some of it was relevant to you. One of the common themes that ran through our presentation is the importance of collaboration. ADHD care cannot be provided by a single person. It's best done as a team effort between the student, the family, outside providers, for example, pediatricians, and you, the educator. As the student ages, the roles of the team players will inevitably shift as the student takes on responsibility for their own care. Keys to success are regular communication and good listening skills. Treatment teams that do both of these things are most likely to succeed and to effectively support their student. Be curious and ask your teammates questions to learn about their beliefs, their concerns, and their goals. And please don't forget to share and celebrate the student's wins. If you notice something that your student is doing well academically or socially, you should call attention to that and celebrate it. Before we conclude our presentation, we wanted to share some of our favorite ADHD resources with you. As Dr. Potts mentioned earlier, we've developed guides for children with ADHD and their families that go from preschool all the way to early adulthood. You can find these guides on the Boston Children's Hospital website. We're really happy with how these guides turned out, so please share them with students, caregivers, and colleagues. Educational videos on behavioral supports can be found on the Seattle Children's Hospital website under their First Approach Skills Training, the FAST program. The website by CHAD, so that's Children and Adults with Attention Deficit Hyperactivity Disorder, also has a lot of high-quality information for individuals of all ages who have ADHD. We recommend that you check out their fact sheets, articles, and resource library. The following books might also be helpful to your students and their families. Smart But Scattered, there's a child and a teen version, and Taking Charge of ADHD, the Complete Authoritative Guide for Parents by Russell Barkley. If you have any questions for us, please feel free to reach out. You can reach me at virginia.peisch@childrens.harvard.edu. Thank you.
We want to thank Dr. Peisch, Dr. Potts, Dr. Dennis, and Dr. Lynch for sharing, and please feel free to reach out directly for any questions or for more information. You can also access resources they shared on the websites listed on the screen. Thank you for watching, and we hope this was helpful for your school community.